Today, we're stepping into the high-stakes world of the operating room. We're going to talk about something that happens every single day, what it looks like when the liver fails during surgery.
Okay, so let's start with a statement that might sound a little crazy at first. Every single major surgery is also a liver surgery. Now, you might be thinking, how is that even possible? Well, even when the surgeon isn't anywhere near the liver, all the stress of the procedure, the anesthesia, the blood loss, the inflammation, it puts the liver through this intense, high-stakes stress test, and sometimes it fails.
So we're calling this whole ordeal the surgical gauntlet. Let's dive right in and see exactly how a standard operation can push this absolutely essential organ to its breaking point.
Right, so liver failure during surgery? It's not just one thing. It's really a spectrum with a few different flavors. First, you've got what's called post-hepatectomy liver failure. This is when a surgeon, say, removes a tumor, but, well, they just don't leave enough liver behind to cope. Then there's acute on chronic liver failure. This happens when a patient already has a sick liver, maybe from cirrhosis, and the stress of surgery is just that final push, the last straw that sends it over the edge. And finally, get this. Even a perfectly healthy liver can fail if the entire body gets overwhelmed by a massive shock, like sepsis or a huge trauma. The liver basically becomes collateral damage in a much bigger crisis.
So, what actually happens when this powerhouse organ gives out? Well, as you're about to see, it doesn't just stay a liver problem for long. It spirals into a body-wide crisis, and fast.
You see, the liver never fails alone. Think of it as the body's metabolic command center. And when that center goes dark, it takes other critical systems down with it. Suddenly, the brain is flooded with toxins like ammonia, which can cause anything from mild confusion all the way to a full-blown coma. The kidneys can just shut down, a really dangerous condition called hepatorenal syndrome. And because the liver's in charge of making all those crucial clotting factors, patients can start bleeding and just not stop. It's a terrifying cascade of failures, like a line of dominoes toppling one after another, and it can overwhelm the body in a heartbeat.
Okay, that all sounds pretty catastrophic, right? But let's zoom back in on that first scenario we talked about, the one where a surgeon just removes too much of the liver. What's the actual mechanism there? What causes that tiny remaining piece to just give up?
Well, the best explanation we have is something called the hyperperfusion theory. And honestly, the easiest way to get your head around it is to think of it as a plumbing problem. Your body is built to pump a certain amount of blood through the liver every single minute. Now imagine a surgeon suddenly chops out, say, 75% of that liver. Well, the body doesn't know that. It keeps sending the same amount of blood, but now it's being fire-hosed through a tiny remnant. It's just a massive, destructive pressure overload.
So what does that look like? This cascade kicks off right after that big resection, leaving this tiny, fragile network of blood vessels. The full force of the portal vein just slams into it, creating this insane amount of pressure and shear stress. We're talking about a physical force that literally batters the liver cells and can even strip the lining right off the blood vessels. And here is the truly wild part, the great paradox. All that extreme stress, the very thing that should trigger the liver's incredible ability to regenerate, can actually shut that whole process down cold.
Okay, so if that's the danger we're dealing with, how in the world do surgeons figure out the risk before they even pick up a scalpel? This question has actually created an entire field of medicine, all about calculating the risk.
I mean, how do you turn something that feels like an art form, judging a patient's inner toughness, into a hard science? How can you possibly predict this kind of risk before making that very first incision?
Well, for decades, the go-to tool was something called the Child-Pugh score. It's a classic, for sure, but it's got a flaw. Part of it is subjective. It relies on a doctor's clinical judgment, like estimating how much fluid is in a patient's belly. It's part art. The modern standard, though, is the MELD score, and it's pure science. No guesswork. It's completely objective, based only on hard lab values, and it gives you a continuous score that's way, way more precise.
And the MELD score, that stands for Model for End-Stage Liver Disease. It's actually beautiful in its simplicity. It just takes 3 simple blood tests. That's it. One for kidney function, one for how well the liver is getting rid of waste, and one for how well your blood clots. You plug those 3 numbers into a formula and it spits out a single number. A number that has profound life or death implications.
And this chart, this is why that number is so incredibly powerful. What you're seeing here is an almost perfectly straight line. It's a direct relationship. As the MELD score goes up, the risk of dying within 30 or 90 days after surgery climbs right along with it. In some cases, a single point increase in that score can mean a 1 or 2% jump in mortality.
This isn't a hunch, this isn't guesswork, this is cold, hard, data-driven risk assessment. So, knowing the risk is one thing, but how do you actually reduce it? Well, this is where medicine gets really proactive. You can almost think of it like a pilot's pre-flight checklist for surgery. First thing on that checklist is figuring out just how much liver you have to leave behind. Because, and this is crucial, not all livers are created equal. A totally healthy liver, it can actually regenerate from just a 20 to 25% remnant. That's amazing. But if you're dealing with a fatty liver or one that's been beaten up by chemotherapy, you need to leave at least 30%. And a scarred cirrhotic liver, forget about it. You need to leave behind more than 40% just to give that patient a fighting chance. So this pre-flight checklist, it starts with really careful patient selection. Sometimes, if the risk is just too high, an elective surgery is simply off the table. Full stop. For those who do go ahead, it means getting them into peak condition, optimizing their nutrition, making them stop smoking and drinking weeks in advance. But here's one of the most incredible strategies. It's called volume augmentation, and it's where doctors actively make the liver grow bigger. It's amazing. Using a technique called portal vein embolization, they block the blood flow to the part of the liver they're planning to remove. This tricks the other side, the part that's staying, into growing bigger and stronger before the operation even starts. It's literally like building a bigger engine to handle the upcoming stress test.
But what happens when all that planning, all that optimization, just isn't enough? What's the plan when the worst-case scenario actually happens? This, right here, is where the medical team deploys the ultimate safety net.
The moment liver failure sets in, the response is an immediate, rapid escalation of care. Step 1 is aggressive supportive care in the ICU. They're basically managing every other organ system to try and buy the liver some time to recover. If that doesn't work, they can literally hook the patient up to machines that act as an external liver, cleaning and filtering toxins from the blood. And if the liver still can't bounce back, there is one final definitive treatment, a full liver transplant.
But you know, while all of this is going on, there's one complication that doctors fear above all others. And surprisingly, the most immediate, life-threatening danger isn't the liver at all. It's what the failing liver is doing to the brain. There's a core clinical saying that pretty much says it all. The #1 priority is to prevent brain swelling, cerebral edema, because that can kill a patient fast.
And look, I know this all sounds incredibly grim, but that ultimate safety net we talked about, transplantation, it's remarkably successful. Just think about this number. For patients who go into acute liver failure and manage to get a transplant, the 5-year survival rate is now 72%. 72%. That is an absolutely incredible testament to what modern medicine can achieve. You know, all of this really points to a fundamental shift in how doctors think about this problem. For decades, the big question was always how much liver is left. It was all about size, about volume. But the future is about asking a much smarter question. How well does the remaining liver actually work? We're seeing a move away from just measuring size to precisely measuring function. And that really leaves us with this final, forward-looking thought. We've watched this field evolve from, crude clinical estimates to incredibly precise scoring systems. The next great frontier is going to be technology that can assess the liver's actual, real-time functional power. So the big question is this. As we get better and better at seeing not just the liver's size, but what it can truly do, how will we redefine the very limits of what is surgically possible?